DMICE research conference that we are trying over time to return to in person. As you know, we have different presentations from either visiting scholars or faculty or students, fellows, and we also have presentations related to our Diversity, Equity, Inclusion, and Anti-Racism Committee. And that is what today's presentation is going to focus on, and it's going to be given by one of our informatics fellows, Chengda Zhang, who most of you know, and I'm going to have a little cheat sheet here so I can talk a little bit about his background. Actually, you went to Peking Union Medical College for medical school? Yeah. We had a student, some of you may remember Tian Jinping in the mid-2000s, who was from PUMC. And she actually invited me to visit. And back, it was about 10 years ago, I was able to visit there. So I think that was before, maybe before you were in medical school. Anyways, we won't dwell on that. But anyways, Chengda is a clinical informatics fellow, as most of you know. And he is, after his medical school, came to the US and did a residency in internal medicine at Beaumont Health. And then he pursued a fellowship in critical care medicine here at OHSU, and always had an interest in informatics. And somehow, I think through Vishnu and Jeff Gold, got connected with us and now has joined our fellowship program. And he is in our master's program, I think. Yes. Yes. So he's doing all kinds of great and interesting things around data science. And I know from his interactions with the committee that he's very interested in a lot of these diversity and equity issues. And he is going to talk to us today, really both present the article and hopefully lead some discussion to the extent we can have discussion in this format while we're still working all this out, on racial bias that gets documented in the electronic health record. And I think those of us who have clinical backgrounds know that this has always been an issue, the comments that get written into medical records. And with the heightened awareness of this problem, various research studies have attempted to document it. And so he'll talk about that, and I'll let him lead the discussion. I'm just the moderator. Paul Gorman, who's the chair of the committee, would have been the moderator today, but Paul is out for a few weeks on medical leave. So I will serve as the moderator, but it's really Chengda who's going to lead the discussion today. So I will turn it over to him. Thank you. And yeah, and then share. I'm going to share. Screen number 2. All right. Can everybody see my slides?
Yes, I
and
can
it's
see.
It's the right slides, not the presenter view, right? Okay.
They look good to me. Yes. Yes.
Okay. All right. Thank you. And yeah, thank you, Dr. Hersh, for introducing me. And today I am going to present this article that is published in February of this year, and from Chicago. And they are talking about the documentation bias, racial bias in the electronic health records. And my name is Chengda. Again, I'm a first-year informatics fellow. Here's the structure of my of today's presentation. I'm gonna start by talking about the background of this article, and then the methods, results, and then I'll put in some discussions both from the authors and also from myself, the thoughts regarding this negative descriptors about patients in the EHR. The main research question in this article is this one. Does providers' use of negative patient descriptors vary by patient's race or ethnicity? And I
further specify this question into this possible causal diagram, and then on the left side we have the race and ethnicity, and the article here is trying to investigate the association and hopefully maybe shine some light on this potential causal relationship between race and the negative patient descriptors. So this is the main focus of this article. So the author said there hasn't been any quantitative approach in terms of analyzing how the difference in the negative descriptors in the actual real world EHR between different ethnic groups. Here is the causal diagram I'm drawing here. The upper part is the things that we already know, and then the bottom part is that this article is trying to investigate. So we know a few things about race and ethnicity in healthcare. We know it may lead to racial discrimination and implicit bias, and such bias can lead to worse communication between the patients and healthcare providers, and it can cause worse compliance from the patient. And both those two factors can come back and reinforce the discrimination and bias, and ultimately leads to delayed care or less care or worse care for the patient. And on the right side, there hasn't been much studies about the negative descriptors, but one study published recently that did mention that for providers, they are shown about those negative descriptors before seeing the patients, they may hold a negative perception about the patient. And that negative perception may ultimately lead to delayed care or less care. For example, in the case of pain management, if the provider saw that the patient had some documented like non-compliance or possible drug-seeking behavior, and then the provider tends to formulate a less aggressive pain regimen for this patient. So here's what we know, and the article is going to focus on the bottom part of this causal diagram here. The hypothesis in this article is that they think that the notes in the EHR with stigmatizing language may be disproportionately applied to racially minoritized patients. And how they go about to prove them. So next few slides, I'm going to talk about their methodology. But first of all, the data source. The data all comes from actually a COVID-19 data mart. There is a potential problem here with using the COVID-19 data mart because all the patients have some relationship with COVID-19, and which means that this data set is not created solely for the purpose of this research. There may be some selection bias I'm going to talk about later, but the author said their data set is pretty complete, so that they want to use this reuse this COVID-19 data mart for their research purposes. And in total, they got about 18,000 patients. And the data they were able to track back to January 1st, 2019. And they are also, they collected the data until October 1st, 2020. At least, so every patient needs to have some sort of notes in there so that the author can do some analysis. So they require that at least one history of physical should be documented on each patient in order for the patient to be qualified for their study. And lastly, one of the exclusion criteria is that they excluded everyone with dementia, which is a condition commonly associated with negative descriptors in the EHR, and does not necessarily have any racial specific distribution. So they excluded this condition because they thought this might be a confounder. The next step is actually building a natural language processing mechanism for them so that they can use this automatic program to read through all of the notes that they ported from the patient charts. The first step of building this natural language processing mechanism is identify all of those keywords that may be associated with a negative descriptor. The way that the author did it, they searched for the term of difficult patients and all of the keywords that may be similarly associated with them. And here I listed the terms that they use. In total, they have 15 of them. For example, they have non-pleasant, non-cooperative, and historical, defensive, non-compliant, or confrontational, or non-adherent, angry, challenging, exaggerate, refuse, resist, aggressive, combative. So those are the keywords that the author is gonna use to retrieve all the sentences that contains those keywords. And then the next step is more involved in machine learning, and they have to build an algorithm that can automatically identify the meaning, the actual meaning of the extracted sentences. For example, a sentence may say that this patient has been poorly compliant. So this is a confirmed negative descriptor for this patient. And then the author will manually come and annotate this sentence as negative descriptor. And they want to have this mechanism being NLP mechanism being able to differentiate negative and positive. So, for example, if the sentence is actually telling the reader that the patient is actually being compliant, and the author will mark it as positive and trying to teach this NLP mechanism that we are actually seeing an opposite of negative, which is a positive. And then there is a third category of sentences. Those sentences not actually describing the patients themselves. They may be describing an object or something or someone else. For example, the word compliant can be used to describe balloon. So this is out. They categorize those as out of context. These steps of manually annotating the sentences is critical in building this model in terms of to help the author scale up their analysis. So in the first stage, they annotated about 6,800 sentences and used them to build a machine learning model. And 2/3 of them in the training set and 1/3 of them comes to the testing set. They claim that their model had a F1 score of 0.935. And they said it's a pretty, it's almost perfect model in terms of differentiating those sentences with categorizing them as a negative descriptor, which is the thing that we're looking for today. So they build this model, and then they are going to use this model to look into all of these 18,000 patients. And then the last step is just statistical analysis, which is the easier part. They basically use the multivariate logistic regression, trying to figure out the association between the race, ethnicity, and the presence of negative patient descriptors in the patient's note. So before building this whole multivariate logistic regression model, usually it's a common practice, and we want to make sure that all the confounders are being controlled. So I put a question mark here. The authors did listed all of these confounders, and they put them into their model. I think language is one of them. It makes sense. It can affect the patient race and also is affecting the patient's negative descriptor. But I'm not sure about the rest of them. 6 factors listed here. Maybe they're confounding factor. Maybe they're just mediators. So the author, anyway, they included all of these factors such as insurance providers, encounter location, or the patient medical complexity, encounter length, positive COVID-19 tests, and timing of encounter. So those factors, I'm not sure they are confounding factors, but the author included them anyway. Luckily, the author did list both the unadjusted and then adjusted odds ratio for the race and ethnicity. So we're gonna see in the results. It's actually, I think, the practice of statistical analysis is fair here. We are gonna the next step. Let's look at the actual results of this article. This is table 1. This table 1 basically is a descriptive analysis that showed how the negative descriptors are presenting across different groups of the patient. In total, they have among all of their patients being analyzed, 8.2% of the patients had one or more negative descriptors in their history of physical notes in their EHR. And the focus of our study here today is mostly on the racial bias. So here you can see the Black patients account for about 60% of their total patient population. And then those 60% of patients actually accounts for almost 80% of the negative descriptor. From this descriptive analysis, we see there might be association, whether the association is significant or not. We're going to move to the next table, which is the major results of this paper. They basically used both the univariate and multivariate logistic regression, prove that race Black is being associated with having a negative descriptors in their EHR. So they have odds ratio 2.84 in the unadjusted odds ratio. For adjusted odds ratio, they have odds of 2.54 with a 95% confidence interval of 1.99 to 3.24. The next step, the author did do 2 more sensitivity testing, trying to see proof that if that's a valid observation from their data. The first step, the author went on to exclude further patients, not just a patient with dementia. They exclude the patient with delirium, substance use, and mental behavior diagnosis. And after excluding all of those patients, the Black is still an independent association, has independent association with negative descriptors with a odds ratio 2.88 and 95% confidence interval 2.03 to 4.11. The next sensitivity testing they did is look at the actual number of negative descriptors in each patient, actually per 100 patients, and compare this between Black and white patients. And they saw that Black race was associated with 5.6 more negative notes per 100 patients compared with white race. So let's move on. So we're done with the results of this paper. Let's move on to the discussion. First, the discussion that's put in by the authors. One of the major, I think, limitations in this study is actually the selection bias that I mentioned earlier. I think the fact that they used the COVID-19 data sets is not actually ideal. One of the reasons is that if you look at the previous slides and on the last line, and they did analyze the timing of the encounter after March 1st, 2020 versus before March 1st, 2020. And they saw that there's an association of decreasing use of negative descriptors after March 1st, 2020. And the author putting some hypothetical explanation, maybe the providers after this COVID-19 pandemic, they are putting more PPE and patients are being in isolation. They're having less interaction, person-to-person interaction with the patient, and therefore they're going to put in less negative descriptors. So that's a possibility. So anyway, COVID-19 may be associated is affecting our results here. So it's not the ideal data sets for us to use to analyze the negative descriptors in patients and trying to figure out the racial bias in that situation. So I think the data set selection is not ideal. And author did argue that after April 1st, 2020, everyone in the inpatient and the ED setting, basically everyone had a screening test for COVID-19. So that means all of those patients in ED and inpatient after April 1st are actually included. So no matter whether they have any association with COVID-19 or not, so they are included in this data set. But the problematic but there is still problem for the outpatient data, and there's still problem for data before April 1st. That's the challenging, the most significant limitations I see for this article. And of course, this is a single center study. It doesn't have too much racial representation of other races other than Black and white. And this is also a cross-sectional study, and we cannot know about the actual effects of negative descriptors on the patient outcomes because it's cross-sectional. So those are the limitations I talked about, and we all saw the results. And I think just by looking at the results, the results is pretty solid, and we are being faced with some sort of racial bias in our EHR. And the question here that I thought about is, what can we do? Can we do something now as an informatician to help minimize those bias? So why is there a bias just based on the race and ethnicity? I think most of them comes from stereotype. Is there a way for us to implement something changes in the EHR to help minimizing stereotyping? One way that I saw on that a group of computer engineering from India is trying to do for Facebook is they implement this app that is intentionally sharing inspiring stories about certain race, ethnicity, or gender groups, so that those stories are aimed to break the stereotype and remind people that everyone should be different, and you should approach someone personally before judging them based on their like race or gender and stereotyping them. So I propose. So I have several thoughts about what we can do here. So first of all, I'm thinking about how to make the EHR more personal. And we, in the past few years, we saw the efforts of putting the actual patient photo in the EHR, which I think is a good effect for our providers psychologically. And I think we can do more. And it's always better to know about our patients personally rather than leave those questions for the provider to judge their patients based on their stereotype. Maybe we can connect the EHR with MyChart and let the patient put in some brief introduction about themselves, so that we know that everyone is different. For me, as a critical care provider, every morning I go to the ICU. I quickly walk through the unit and see if everyone is unstable. And at that time, when I'm standing on the hallway, just looking at everyone looks the same. They are all having some sedation, got intubated, having some shocky physiology. But once you start talking with the patient's nurse, you walk into the patient's room, and sometimes you can see the patient's their family photos and the picture taken when they were healthy. So it has a different effect on me. And you start to realize that everyone is different, they have their own needs, and the provider should be professional and stop being and stop being using any like stereotyping language in your notes. The second suggestion that I have here is maybe we can implement some more like 360-degree evaluation for the patient, especially in the inpatient side. The way that we are right now collecting like negative or positive descriptors from the note is actually by just reading the note from the admitting physician or the ED physician, just one note. But I think that's unfair for the patient. So first of all, the patients come to the hospital, they may have different illness. They just have different pathophysiology. So that's for sure is impacting their mood and will impacting their interaction with the providers. And secondly, certain patients may have like better or different interaction with certain ethnic groups of providers. So I think the better way to actually putting an evaluation about the patient behavior is in the EHR, we can include a section that uses NLP techniques to pulling all the negative and positive descriptors in the past for this patient, so that the provider, once they saw this section, they have a general overview of the patient's behavior in the past, not just from the admitting physician's one note. That way, I think it's being more fair for the patient, and you can see the whole picture of the patient in the past. And then thirdly, I think one of the things that we can make changes in the EHR is maybe put some explanations beside the negative descriptors. For example, if a note is saying that this patient is being non-compliant, and then our EHR can goes into the previous information and retrieve relevant medication and diagnosis that may explain the patient's behavior. For example, someone said this patient is being non-compliant. And how about we go into the EHR and see if the patient actually have been diagnosed with dementia. And that way, provider, once they see that patients are being non-compliant, they also understand that the patient is just physically incapable of being compliant to their own healthcare. So that's all my 3 thoughts, suggestions. So based on the results and of this article, and anyone has any questions, and I would like to open for open discussion about for this article. Thank you.
Great, thanks. Sure you repeat.
Oh yeah. And yeah, the good question. The question here is why there is such big effects of marital status with negative descriptors here. Here, but you can see the results part is showing that marital status is actually, if being not married, has imposed a significant risk of having negative descriptors, both in the unadjusted ratio and adjusted ratio. So this is a solid observation, and the author did mention that in their discussion part that they think the data is real, and they think there is an association, but they don't specify why. Yeah, and I don't think the data here in the article is enough to ask the question why there is association we are observing. Yeah, and regarding the question for race and ethnicity, no, they did not look into whether certain race is less likely to be married or not.
You think a different data set besides that with the date specific issues just comments and interaction. Do you think that they use a different data set than senior disparity?
Repeat the question.
Yeah. So the question is, if we use a different data set, maybe not just for COVID, but maybe a better data set representing actual patients, and are we are we gonna see a stronger association between race and the negative descriptors? I don't know. It actually depends on what happens in this data sets, and after, for example, after March 1st, are we observing more admission of Black patients versus white patients? And then in that case, since those patients are getting less negative descriptors, and I suppose that if we use a different data sets, we're going to observe even more disparity. However, I'm not sure if that's the case, and maybe maybe it's the opposite case, and they are just admitting more white patients, and in that case, then we're going to see less. So yeah, the answer is that we don't know yet.
Share your slides and some chat traffic.
Yeah.
Chengda, this is Chris. My question in the chat is about the diagram that's early on in your slides. So I don't know if it would help to show that causal pathways diagram again when you come to answering the question, if you'd like.
Sure. Actually, let me figure out. Let me first pull up my chat. I haven't seen the chat yet. Return to meeting. How can I see the chat here?
Yeah, you can click on it. Yeah.
That's all I see here. Oh, here. Oh, yeah. Oh, that's
where it says chat to the right. I guess for you, we go this way.
Okay.
Yeah, that one. Yeah.
This one?
Yeah.
Okay. Yep.
Are you in a different screen?
Yeah, I'm in a different screen here. Let me just stop sharing. Okay, that's better. So questions. Question. Let me show the diagram here.
Feel free to take the other questions if those are easier for, yeah, perfect.
Yeah. So we have the diagram here.
Yes, perfect. I was curious, I know you talked a lot about this data set maybe not being the data set that you would hope for this question. I thought there might be a direct line from worse compliance to negative patient descriptors that didn't come through a pathway of care or perception, but just comments about, negative comments about the patient, about compliance, that compliance would lead to that directly without going through the other arms of the pathway. And I wondered, with the data that you have in that study with that journal club, would they have been able to assess whether it goes through a pathway of delayed care or less care, or if it's more direct in the sense of the way you presented their findings to us? It seemed like you could go directly from bad compliance to the negative descriptors without maybe going through the care pathway. And what are your thoughts on that? I realize it's not your data, but I was curious from what you saw. Yeah, thank you.
Yeah. So are you asking about different data sets that we have access to?
I think I'm just asking, the way they studied the question, it seemed like they kind of went directly from worse compliance on this diagram to negative patient descriptors, and they didn't have to go through those arrows of compliance equals delayed care, less care, delayed care leads to negative perception leads to negative descriptors. They kind of, in my way of understanding your presentation of their work, they kind of went straight from worse compliance with an arrow down to negative patient descriptors. And I didn't know if that was just me missing a step or two in what they had presented, or if you felt like maybe they were drawing that line directly without their pathway.
Yeah, I think there theoretically there should be a line from this worse compliance to the negative patient descriptors, and all of those factors looks that they're going to interact each other. I think negative perception can also lead to worse compliance, and worse compliance can feedback and reinforce a negative perception here. This is a very complex network here we're looking at. I don't think the data itself is being a retrospective cross-sectional data is going to show us much about the causal diagram here, but the only thing they're trying to prove is the association, whether it exists here in the bottom here with this one. In order to do some more subtle analysis on this causal diagram, it's going to be challenging, and I think there may be ways of analyzing it, but I'm not an expert in that field.
Thank you. That was very helpful.
Thank you.
I have a question about
Yes.
you can select this article.
Yeah.
There were 2 articles essentially on this topic that were published pretty close to one another. What made you choose this one over the other one?
Actually, I'm not aware of this, the other JAMA article. The question? Sorry, the question is why I'm choosing this article. There seems to be another article published in JAMA, and do you mind describe that article?
Yeah, so
quickly?
This article from JAMA is also examining stigmatizing language in the electronic health record and found similar association between stigmatizing language and Black race. But it also kind of addressed some of your data set issues. So it took all admissions and did not relate it to only one single diagnosis. And it also looked at author factors. So, who wrote it?
Yeah. Okay. So, in summary, Dad just mentioned that this JAMA article has better data sets and to represent to answer the research question, and it also addresses the race of the provider who are documenting the notes. Actually, I'm seeing a question from Homer about the race of providers in this article. So in the one that I'm presenting today, they did not mention about any provider's race that's affecting the patients their documentation. So I think there definitely that article Dad mentioned in JAMA is sounds to be a better quality article, and the reason I choose this one, I think it's interesting, and it's more and it combines the like NLP techniques and machine learning and their own analysis. And if I read the JAMA article, maybe that's a good one to present side to side and to give people a better view about this topic. The next question I have is from Benjamin. is he wonders if they should have controlled for the number of notes per patient, or at least evaluate for an association. That's a good question. Whether they should control for the notes, the number of notes for the patient. They did do an interesting analysis that I mentioned in their the sensitivity analysis, and trying to see how many negative notes in each patient, 100 per 100 patients have in their group. And they kind of imply that the more notes you have, the more negative, like the more negative that you got for the as a description from your providers. And I'm not sure about that. Maybe so. Right now there are a lot of copy pasting of the notes, and if you have maybe one provider putting concerns about patients being non-compliant, and other provider may just copy and paste, and you end up with multiple notes. So I think that's also part of the reason the author focused only on whether or not a patient had a negative descriptor, rather than the number of notes. Yeah, that's my answer. I think there may be value to prove your major results in terms of analyzing number of notes, but there's also limitations in doing that analysis. And then the other question also would like to have seen an evaluation of demographic data quality by the authors, as this data in EHR is often inaccurate. That's exactly the point. Actually, I am in our OHSU's disparity dashboard, and we have been trying to build some data elements that can better represent patients' race and ethnicity group, and it seems like there is a lot of challenging in building this just this single data elements. And think about that, the patients can define their own race and ethnicity. They may present as one race for today, and then they decide to change it for the future. And it becomes a complex data storage issue for the future. So I think that's the challenging part, and author did not mention about the quality of data source, and I think it's fair to assume that their data elements is not better than the average EPIC data elements that we have available right now. And then next question, is it possible that the associations are picking up on real disparities and not negative stereotyping? For example, a Black patient may very well be less compliant or more argumentative because the treatment plan will cause an economic hardship, loss of wages for not working. The variables included in the analysis suggested that the variables that could be potential proxies for economic status have a strong relationship. That's a question. I think that's a solid point. We do see. Let me see my own slide. Maybe I can read off the main results here. So it seems that there is a difference in terms of patient insurance providers, and if you are on Medicaid and Medicare, you do have higher odds of getting a negative descriptor. And if the patient is on, and then the patient is having more higher Carlson comorbidity index, which like medical complexity, they also tends to have a more negative descriptors. So I think this is a fair question. It's a good point. And to think about educating providers one part, and there might actually be some challenges in helping those patients because they are already suffering from unstable financial situations. So that's so I think that might be another way to address the current problem that we are noticing in this article. Good question. Thank you. And then lastly, we have Vishnu a question. As Chengda noted, I also wonder about how the pervasive copy plus pasting that exists in the workflow today may propagate biases in charting from one provider to another. Yeah, I think that's definitely affecting our documentation for the patient.
Chengda, I just wanted to make a comment. What a very good presentation. And one thing I really liked was that you brought out some next steps, which the authors did not seem to do. I got a sense from the conclusion that they made a conclusion, but they didn't really say, well, we found this out. What are we going to do about it? That was just my sense of it.
Yeah.
And I don't know, because I come from the University of Chicago, I kind of know like they were looking at it in a theoretical way.
Okay.
Which is they do. But I thought what you were doing too is that there are ways that we can change how we're doing this, that kind of thing. So I just want to say that.
Yeah. Okay. Thanks, Catherine. And I think there are definitely multiple ways, and the patient needs support, our provider needs support, and better education as well. So I put in some preliminary recommendations from implementation standpoints, and I do see this going to be a team effort, multidisciplinary, both the patients, primary care providers, and patients primary team, and as well as the social work and team that can work together, better supporting patients with racial minority groups. Yeah, you have a question?
Yeah, the question's actually related, but she was asking about solutions, and I was like, I should think it has some solutions.
Yeah.
And if not, what sorts of facts would be helpful? What sorts of questions should be that's really
Yeah, I'll try to repeat your question. So are you asking us like is there any sort of like data can be helpful for us to explore and find out or point out a way for us to address this observed problems here? Yeah, so in the data itself, I think if you look into more details, like we just did, we find out that there's some patients with certain insurance providers and indicating maybe a lower socioeconomic status is having trouble, and that can shine some light, and you can see some association that is causing the problem. And really, for this cross-sectional retrospective study, you can't really tell if it's a causal relationship or if it is just a simple association. And we already have such a complex causal diagram here to analyze. And I think if you look, if you do some like subtle analysis on the subgroups of patients, you may see something. but it's not going to be definitive, and it's not going to tell you for sure that this is a problem. Again, it's going to be a multifactorial, and it's going to be a big project to address. But I think that I believe that if you look into the details of the data, nuances of this data, and you should be able to find some of them. Yeah. Thanks.
I actually thought maybe I would. It's really more of a comment than a question. I thought I would just come up here so you didn't have to repeat it. But so one issue. This is Bill. I don't know if people can see me or not, but they probably recognize my voice. One issue. One thing that this study, I guess, because I'm always thinking about, well, what can we do with EHR data? All these great things we want to do with it, research, quality measurement, et cetera. And I think these findings, and also the other paper that Da refers to, are kind of a window into the, some of the issues with the EHR. We sometimes tend to think that, the data in the EHR is almost sacrosanct, that it's this absolutely medically objective view of patients. And, we're going to do other things with this data. We're going to apply machine learning algorithms to it and so forth. And so I think another realization, and I'm actually trying to figure out how to turn this into a question, but, how do we improve this part of the data in the EHR so that our machine learning and other algorithms are not led astray by other biases, not only these biases, but maybe there's other biases in the record as well, that will undermine, what we hope to do with being able to predict things and, give people good advice and so forth. I don't know if there's a question there, but I don't know if you or anyone else has any comments.
Yeah, that's a good point.
Okay, are there any more? We're just about at time. Are there any more comments in the chat? I don't know that I can see the chat. We will hopefully make this, it's going to be a learning experience to figure out how to do these in a hybrid way.
Yeah, no more.
No more comments in the chat. Okay, well, this was a very interesting, very nice presentation and interesting discussion around it. I think that there are many issues that we as informaticians need to think about. So thank you, Chengda, and we'll see everyone at the conference next week.
Thank you. Thank you.